My name is Donna Klassen, and I am the co-founder of Let's Talk Menopause. I am a licensed clinical social worker, and Let's Talk Menopause is as a nonprofit, changing the conversation around menopause so women get the information they need and the healthcare they deserve. Our menopause talks are central to our education efforts. We have 30 prior menopause talks on our website at letstalkmenopause.org/talks. All menopause talks are intended for informational purposes only. They are not as a substitute for professional medical advice, diagnosis, or treatment. There's a few housekeeping items. We've disabled the chat and we'll use it only to provide you with relevant links. So check there throughout the talk. Please ask your questions in Slido, and we have provided that link for you. There will also be a brief survey at the end through Slido, and we ask that you complete it so that we can continue to improve our programming. Today's topic is vaginal estrogen, the shockingly underprescribed gold standard for maintaining sexual and urinary health in menopause. We have today Dr. Rachel Rubin, and there are few better able to discuss this topic than Dr. Rachel Rubin. Welcome, Rachel. Dr. Rubin is a board-certified urologist and sexual medicine specialist. She is only one of a handful of physicians with a fellowship training in sexual medicine for all genders. She's a clinician, researcher, and passionate educator and advocate. She is the former education chair and current director at large of ISWICH, which is the International for the Study of Women's Sexual Health. And we will actually have for you in the chat later on a link to where you can find a provider of ISWICH. She is also the associate editor for the Journal of Sexual Medicine Reviews. So we're going to break this up. We're going to start this menopause talk, and there's going to be 3 sections. The first section is going to be about genitourinary syndrome of menopause. What is it? What are the symptoms? And what can you do about it? The second part is about the difference between local hormone therapy and systemic hormone therapy, getting into a deeper dive about how that can help with GSM. And then the third part is going to be about barriers to access and use and how to overcome them and what you can do about it. So I'm going to just start. So welcome, Dr. Rubin. Thanks for being here. Can you explain to us what GSM is, what causes it? Tell us more about it.
Yes. Oh, I'm just so happy to be here. And can I just say, I love Donna Klassen so much and what she has created at Let's Talk Menopause. It is so incredible to not be the only person screaming and yelling about this. And, you know, when you said few people are better than Dr. Rubin at talking about this, it breaks my heart because everybody should have the skills and the tools to loudly advocate and talk about this very simple problem. Like, this is actually a simple problem with a simple solution. And so the fact that we're having so much trouble advocating and yelling and getting people on this life-saving therapy is a disaster, which is why I am so thrilled to do this. I'm so thrilled to be here and to see so many incredible people on a Monday afternoon watching us. It just warms my heart and totally fills my cup. So I know we have a slide, Ada, if you can pull up the next slide. I want to talk about the symptoms. So Genitourinary Syndrome of Menopause, GSM. I want everyone at their computers to say the words GSM, I guess the letters GSM, Genitourinary Syndrome of Menopause. So this is what happens when the bladder and the genitals don't have hormones, okay? When the bladder and the genitals are so hormone sensitive, they are filled with receptors of estrogen, of testosterone, and like a plant without water, if they do not have those hormones, they lose that that excitement that a plant, you know, a full healthy plant, and so it gets dry, right, without water. So hormones are like water to the bladder and the genitals, and so we didn't really understand that in these terms up until sort of quite a few years ago, where we used to call this a little vaginal dryness or vulvovaginal atrophy. That's sort of what medicine really studied this topic, but it's not just a little vaginal dryness. That minimizes what is a very significant and a dangerous condition that affects pretty much all menopausal women. Now, the problem is this isn't like hot flashes or night sweats, which sometimes get better for people. This is a chronic and progressive thing that tends to only get worse and worse. And the problem is we don't talk about it and empower and tell people. So you may get symptoms like dryness, pain with sex, and it can affect your sexual health, which can affect your arousal, your orgasm. But it's not just about sex. It's itching, burning, irritation. It's pain with urination, urinary frequency and urgency, sometimes urinary leakage. And the thing that can and does kill people is recurrent urinary tract infections, right? Because the bladder really needs these hormones to be acidic and healthy and to fight infection. And so if we go to the next slide, this isn't just symptoms, which many people have, at least almost all people probably have at least one symptom of GSM, but we minimize it. We don't talk about it, nor do my colleagues, the doctors out there, really think of these things as hormonal problems, which is why my advocacy and our advocacy is so important, because your doctor may not realize that these are symptoms that can affect people before menopause. This can happen in your 30s or 40s and long after menopause, meaning you can be 80 or 90 or 100 and have GSM symptoms because of the lack of hormone. And you can see the changes with your eyeballs. You can see the flattening of the vaginal tissue, which is usually supposed to be very wrinkly and stretchy. You see it get flat. You see it become thin and friable and pale and irritated. It can bleed with the lightest touch. It can decrease in lubrication. Like, you can see this with your eyeballs. And you can go to the next slide. Not only does it affect the internal vagina, but it actually really affects the external vulva, which is the outside parts. You can see, actually, this is crazy, right? You can see women have decrease in the size of their labia minora, which are those inner wings. They resorb, which is called, they basically can, for some people, shrivel up and disappear. Now, they may not completely disappear, but they change. And again, I always say, if you've ever heard me speak, you've heard me say this, is if a penis shriveled up at age 52, we'd be talking about it. We'd have a vaccine Pfizer would have a vaccine available. But no one even tells women that their labia may change, that their clitoris may change, that the tissue becomes pale and red and irritated. And go to the next slide, because this is actually a life and death condition. Okay, women over 65, right? 20% will get urinary tract infections. Between 50 and 60% of adult women will have a urinary tract infections. And UTIs account for 7 million hospital visits annually, and 25% of all infections in older people. A quarter of all infections that try to kill old people are urinary tract infections. And we know that vaginal hormones decrease the risk of urinary tract infections by well more than half. It's unbelievable how good it works. And it's preventative and it's safe and it's so effective. And again, this data is so crazy that for older patients with a UTI related healthcare expenses consume a third of the total Medicare yearly dollars spent on their care. And so we published a paper last year that showed that we could save Medicare between $6 and $22 billion a year. That's billion with a B. If women were using and had access to vaginal estrogen, you cannot make this stuff up. And so I think that was our last slide for this section. Donna, is that? And I'll let you.
I think that's it. I think you gave a great framework of what GSM is, right? And I guess one more question about GSM, and then we'll move on to the difference between vaginal and local vaginal and systemic. So I think the main point that you said is that it's chronic and progressive. It does not get better without treatment. There's this constellation of symptoms. Many women get them, right? And it's untreated right now. People don't know about the treatments for it, right? And that the main thing also is that the UTIs, which I know my mother-in-law, my mother had chronic and progressive. I mean, they get it all the time, which can affect their cognitive health, which is, it's such a burden on society. And I know for myself that when I am with my friends and I ask them, are you on local vaginal estrogen for, GSM or vaginal dryness? They say no. So let's go though, just to the framework of how did we get here with hormone therapy and explain the difference, because I think this is really important. The difference between local vaginal estrogen and systemic hormone therapy. So can you just give us a little
This
bit of history, which I know is hard to
this
do in
is
a couple minutes?
so no, this is so important. This is so important. And Ada's going to pull up a slide here actually that we do have to talk about the difference, because not all hormones are the same thing, right? Not all hormones are the same thing. Let me think about birth control for a second. You've got a condom and a birth control pill. They're both contraception, but they're very different things with very different side effects. And I think it's important because we have to understand that not all hormones are the same thing. Not all doses of hormones are the same thing. Not all ways that you get hormones into your body are the same thing. And there is a huge difference, I mean, huge difference between low dose local vaginal estrogen, which treats GSM, the Genitourinary Syndrome of Menopause, which
Rachel,
is safe.
I'm going
So
to
that
interrupt you 1 second. We're getting away from low dose. I think it's actually really important because there are some low dose systemic, right? And it is a lower
fair.
dose,
So
but it's local. I think that's really, it's like a top
local, I think that's great.
local.
So local, yeah. So local, I think that's totally fair. So local vaginal hormones are safe for everyone. Great grandma in the nursing home, your Aunt Millie who has a history of blood clots, your sister who's 45 and a runner and is leaking and still gets her period. It is safe it's safe for women who are lactating and breastfeeding and have dryness and pain. Local vaginal hormones, okay, which includes estrogen and something called DHEA, they are safe for everyone, and they treat the GSM, the Genitourinary Syndrome of Menopause. Now, that is totally separate and different from systemic or whole body estrogen therapy, which we use to treat hot flashes, night sweats, and prevent osteoporosis. And so they are, and the systemic whole body estrogen sometimes can come in a pill form, a patch form, a ring form, a gel form. Those are the different options. But the local vaginal estrogen is typically a vaginal estrogen cream, an insert. There is a ring that can be used for 3 months at a time, and different kinds of suppositories. So there's about 5 different types of local vaginal hormone products, and there's many different types of systemic hormone products. But the problem is that your doctor doesn't know the difference. And the doctors, so this is why it matters, is because women are dying because of a lack of education. That's it. Because we have said that women's health gets all delegated into a tiny field of medicine called the gynecology, and menopause medicine gets delegated to an even tinier field because most gynecologists are not trained in medicine. That is what the research shows, and that is what patients' lived experience shows. And then menopausal medicine is an even tinier niche. This is half the population. This is millions of women getting urinary tract infections, which affect their quality of life and their actual life. And so this is so wild how simple this is. This is actually a simple problem that has had a simple solution since like longer than the 1970s. We've had it. We've had the treatment. The treatment has worked. There has been data and evidence that whole time. It's a marketing problem. It is literally that we have not marketed this well to your doctors, to the patients, and so women are suffering needlessly. That's the wildest part, is they're suffering needlessly.
So let's talk a little bit about the safety of local vaginal estrogen. So local, vaginal estrogen, and maybe let's go back a little bit just to talk about why it's lumped together. Can you just give like a
Yeah, Ada, you can get rid of the slides now. I think we're good on the slides. So this is okay. This is bureaucracy at its finest, right? In the early 2000s, this big study came out, a $1 billion NIH study called the Women's Health Initiative came out and made everybody very fearful of hormones. There was a press conference before the paper was ever got out, and Matt Lauer got on TV and said, "Oh my God, hormones kill people. They're dangerous. Everyone throw them in the garbage." And that is what happened. Everybody threw them in the garbage. But remember, I said not all hormones are the same thing. And there was no headline that had the nuance, that had the ability to see the gray, the difference between local versus systemic. There was no nuance. And so for 20 years, we've been clawing our way back to say, wait. actually, hormones are not so good or bad, right or wrong, evil or amazing. Like, they are a thing that helps people. And like with any other thing that we give people, there's risks and benefits, and there are differences, right? We understand that there are, like, all antidepressants are antidepressants, but they all have different, side effect profiles and different nuances to them. And so, but in 2003, the FDA said, oh my God, this big study came out. We think everything's dangerous. We are going to just put a label on all hormone products. All hormone products are just going to have this big, scary label that has a box around it that everybody can see that says hormones cause stroke, blood clots, heart attack, probable dementia, must be, if it's an estrogen product, must be taken with progestin, and this might kill you. Okay, so whether it is a local vaginal hormone, it has that label. Whether it's a systemic hormone, it has that label. Whether it's a pill or a patch or a ring, it has the same label. The problem with that label, the FDA was saying, oh, we got to be careful. We're going to put it all in everything because we just can't hurt women. We don't want to hurt women. But by putting that label on there, they're not only hurting women, they're killing women. This kills women because there is not a paper on the planet, and anyone can listen to me. I'm talking about this on the internet for 7 years, and not one person has presented me a paper that counteracts what I've been saying, because it doesn't exist. There's not a single literature paper, there's not a single academic paper that says that vaginal hormones cause stroke, blood clots, heart attack, dementia. There's no paper that shows vaginal hormones cause breast cancer, and there's no paper that shows that vaginal hormones cause mortality from breast cancer. In fact, we've had a paper come out this year that shows women with breast cancer, 50,000 women with breast cancer who take vaginal hormones had less chance of dying than those who did not use vaginal hormones. It's wild, right? Like we have data that shows life-saving effects of these products, and yet nobody tells you this.
Right. So I think, I mean, what you brought up nuance before, and I think that is hugely important, right? That we don't know how to do nuance in this country, in this world. and but I do think that with local vaginal hormone therapy, you're actually saying there's not a lot of nuance there. You're actually saying there might be nuance in systemic hormone therapy, that there are some slight risks that people need to look at, and that they need to balance their own, their own profile and talk to their doctor about it. But with local vaginal estrogen, you're really saying that you really think everyone should be on local vaginal estrogen.
So the problem with me saying a blanket statement, and I'm a big believer in prevention and risk benefit discussions. But in a way, there are data-free zones. There are patient populations that have never been looked at with large studies. And so I will always push to, I would love to see more data with these patients. I'd love to see more data with those patients. But up to date, there is no data, none, that shows a scariness or a harm with vaginal hormones. The one patient population which needs to be looked at closer is a woman with breast cancer actively on aromatase inhibitors. That is not on tamoxifen, not on no therapy. So there you are, right, Donna? You're on an aromatase inhibitor. So there are 2 papers that are poorly done and not great papers from long ago, which potentially show a slight increased risk of recurrence, but no increased risk of death. Now, those were done at a time where local vaginal hormone doses were a bit higher. They were done at a time where HER2 new status and some of the newer therapies from breast cancer were not out yet. And so even those papers, the experts have said there are flaws within those studies. But we have lots of data to show that if you get a urinary tract infection or recurrent urinary tract infections, it is going to impact the quality of your life and potentially your life in a very significant way. So I know that you choose, and I don't want to tell people what you do with your body, but I know that, people choose to use vaginal hormones because the benefits outweigh the risk in your mind. So other than that patient population, which is a small subset of patients out there, I would argue there is no patient on earth who I do not think deserves a discussion on the knowns and the unknowns of local vaginal hormones. And so does that make sense? So I think, and the push for this of getting, the more we get researchers, people, they want research just to magically appear, right? Like, researchers have to care about the question enough to do the research, which means they need to know there's a problem. So the more I open my mouth and start yelling and my friends start yelling on social media, we have started to see research come out. In fact, a paper came out this morning, Donna, by my friend, Dr. Una Lee, who's a chair of urology out on the West Coast. And she just published a paper with her team. It's just beautiful. They polled 1,500, listen, literally, I saw that this morning. 1,500 women they polled in the menopausal age. Every single one of them had at least one symptom of genitourinary syndrome of menopause. Only 20%, only about 300 people were offered vaginal hormones. And of that, more than 50% didn't use it because they were afraid because of what the label said. So we have this huge problem. Very few people are being offered it. And even those who are being offered it are afraid to use it because it's a marketing problem. Like, that is what is so fascinating. But that
Right.
research only got done because we're yelling and screaming, and now they're
Talking.
starting to look at it.
It is actually really interesting, right? Because look, I have breast cancer. I'm pretty open about the fact that I have breast cancer, and the breast cancer nonprofits and the breast cancer world has done an amazing job in educating women, and the progress that's been done has been fantastic. And I think that women often only think about breast cancer and don't think about other things around their health, right? Does that make sense? It's sort of like breast cancer is one of those things that we have to look at. And the great news about breast cancer is fewer women are dying from it. It's more treatable now than it ever was. And it doesn't mean a death sentence. And I think, of course no one wants to get breast cancer, right? I didn't want to get breast cancer, right? But I do think that it's when I talk to my friends, it's the first thing when we talk about hormone therapy. It's, well, what about breast cancer? What about breast cancer? What about breast cancer? But no one's
so Donna, can I ask in front of the hundreds of people on this webinar, is this a therapy, vaginal hormones, local vaginal hormones? Is this something that you are interested in using?
So it is. I use, more. I'm still afraid. I have to say, I'm going to be perfectly honest with everybody. I am still afraid because I'm still on an aromatase inhibitor. I'm on a anastrozole. And, I guess, one of the things I think that people really feel, and this is something that I talk to people about all the time, is it's like, you don't want to do something that you can look back later on and say like, oh my God, I did that. But you actually don't know, if that's the case, right? And so I think that's why people have such hesitation with different things, with vaccines, with so many different things, because you're actively doing something. And with systemic hormone therapy, it's this active thing that you're doing that could then be like, oh my gosh, what if I get breast cancer, right? And so, but what people aren't looking at, and what maybe I'm not even looking at, right, is the benefits. Now, I'm not somebody who has UTIs. My mother has a history of UTIs, but I've never had one. But vaginal dryness, absolutely. I went into surgical menopause and it was like night and day, like literally night and day. Because I went from knowing that I was perimenopausal, and then after my surgeries, I had a double mastectomy. I was postmenopausal, right? And so it was literally like, oh my God, right? And so I don't know what to do.
And this is where, and this is where, as a doctor, in a 10-minute visit, right? If you were in my office and I had 10 minutes only with you and you said that, it would be, oh, sure, you don't need this. Like, we'll do something else, or we'll do this other thing. But at some point, right, you have to meet people where they are. And you also have to help guide them through it and realize that, like, your fear of this, like, it makes sense. It's not, there's nothing wrong. Like, it makes sense. And then there's but it doesn't necessarily mean the data doesn't support, right? Different, like for most people, they say, oh my gosh, Donna's on aromatase inhibitor, she's afraid, which means me with no family history or no medical problems, now I'm afraid too. And I think people don't realize the safety, and there's no paper that's going to make them feel comfortable. But again, when you're pregnant, your estrogen's 3,000. There's no increased risk of recurrence or progression with breast cancer, right? In people who are pregnant, your estrogen is 3,000. When you're in menopause and use local vaginal hormones, your estrogen stays in the menopausal range. It doesn't go up to any level. And so, like, speaking to people in numbers and speaking to people with the data, it's good. But the key is understanding what people are afraid of, helping them see that there are risks. I think this is really important. There are risks to not doing vaginal estrogen, right? So the big risk, and they're big, they're not small, they're actually big. The risks of not doing vaginal estrogen are dying from a urinary tract infection, getting infections so badly you can't go travel or see your grandchildren or go and play mahjong with your friends or go dancing or go, right? Like, these are serious risks my patients talk about. There are risks of not being able to wear the pants you like to wear. There are risks of not being able to get through a long car ride without urgency, of needing to know how many bathrooms are on my way to my work. There are risks of lacking intimacy with your partner, so much so that I see divorce happen. I see relationships break up, and I see people being so miserable because they have shards of glass feeling in their genitals when they have sex. So there are real measurable risks to not taking vaginal hormones. And the risks of taking vaginal hormones, I don't have any data to show me that there's death. I don't have any data to show me that it causes cancer. I don't have any data. In fact, I have data to show me that if you've had a blood clot before, there's no risk of a future blood clot with vaginal estrogen. I have so many papers that say there's no risk. And so yet, how do you balance that, right, with the serious risks of what happens when you don't take it, and the risks like of taking it? You can't find me a paper that shows real measurable risks to taking it. Now, if new data comes out, you guys, who's going to be the first to know? I get Google alerts, right? Like, I'm going to be the first to tell you, right, when new data comes out, and we adjust. This is the way life works and science works. Is there is, of course, things that we don't know, but we're constantly pushing to get those answers.
Yeah. And I think that, I mean, I tell all my friends, I tell everybody to go on local vaginal estrogen, everybody, right? And I think the one population is with breast cancer, right? And so I think that that's something that, and I think that when I stop, I plan on it, right? Like when I stop my aromatase inhibitor, which is going to be another 6 months or so, that I would then start to take it, because it is problematic. Even though I don't get UTIs, it is problematic, right? So
there's some beautiful data. There's some beautiful data coming out by people who've looked at using vaginal DHEA, which is not estrogen, and using it with an aromatase inhibitor. And you see the continued support of the vaginal and bladder tissue, but you continue to have the aromatase inhibitor, which blocks the conversion to estrogen. And so we are looking, like my colleagues and people in the space are looking at these different products, so that maybe, someone who hears the word estrogen and they say, oh my God, I had an estrogen positive cancer, that scares me. Again, there's no data to support that it should scare you, but it still might scare you. To say I'm taking DHEA, which I can go get it at the supplement store, I can go get DHEA, over the counter. There are products with DHEA that are FDA approved that help GSM. So vaginal DHEA, it's a product called Intra-Rosa. And so we come up with ideas like that. There is a vaginal estrogen insert, which is 4 micrograms, which is so small, it's barely a blip in, like, it's barely a raindrop, right? And that alone will prevent urinary tract infections. And so we work with our breast cancer patients to really find a thing that makes sense for them. But again, this is why not only are 10-minute doctor's visits inappropriate for most people, I think any human on earth, but this is why you have to have a knowledgeable doctor who's going to meet you where you are, but also push back a little bit. Like it's kind of important and to push back and to really see, well, what is the fear? And is this really helping your symptom? Do you have to suffer this way? Like, is this worthwhile? Because a sip of wine, right? A sip of alcohol increases your risk of breast cancer recurrence, right? Eating French fries, which are delicious, increases your risk of, cancer recurrence. And not exercising, right? All these things like that we do that increase our risk of cancer. We take the risk, right? Like I don't run every day. My knees can't handle it. But like, there are things that I don't do, right, that I know are increasing, potentially increase, that we're human. And so having sex is human, and it's you're worthy. Like, you should, if you want to have sex, you should be able to. You shouldn't suffer. You shouldn't have to get up at night to pee, because if you're not sleeping, that's going to kill you a lot sooner than any cancer is. If you're, having or urinary urgency to the point where you can't go on trips, that's affecting your quality of life. And so it's really important to talk to somebody to help you through that.
Right. And I think that's super important, because I think that this idea of risk, right? Like, when you do something passively, like by not exercising, that's a risk factor. That's a passive thing. Taking hormone therapy is an active thing, right? And
Well,
people don't. What I'm saying about that, though, is that it's the same. It's a similar risk, but people, I think, because it's active, I think people get more afraid of it. Does that make sense?
So it's not similar risks. There's actually much more risk of those things. There are measurable risks of, and alcohol is a perfect example, right? You have to choose to drink a glass of wine with your friends, which I'm not telling anyone not to do. If it gives you joy and brings you fulfillment, you rock on. But we have measurable, real risk with alcohol and breast cancer, real, like significant risk. You know, it's not nothing. There's no risk of vaginal estrogen in these patients, none. There is no measurable risk. There's not a paper on earth that will tell you what the measurable risk is. And so you can't compare them and say, oh, well, I drink wine, but I won't use vaginal estrogen, you know, because it's dangerous. That's actually not, that doesn't make any sense. But we do lots of things in this world that don't make sense, right? Like we don't have, our brains are, you know, just like you said, we don't do nuance well. If it makes sense to us, that doesn't mean that it logically makes sense with the data. But we have to still meet you where you are. I can't be mad at you for drinking alcohol but not using vaginal estrogen. I have to try to understand and break down what are the decisions, and can I support you in that? Because I will tell you, this is something we didn't talk about yet, but taking antibiotic after antibiotic after antibiotic for a urinary tract infection is dangerous, like really dangerous. Why? Because you're going to get resistant bacteria. You're going to get side effects of antibiotics, which are terrible for your gut microbiome, are terrible for your GI tract, and many other things. And there's actually data to show recurrent antibiotic use increases inflammation, increases infection risk, and there is breast cancer data even associated with that. So by not using vaginal hormones, potentially your risk of other very harmful things increases. And so it is hard for people to see that logic, which is why I'm so loud about this, because it pushes. I am the doctor that I push back a little bit, and I don't push in a hard way. I meet you where they are, and then I tell people when they're advocating about these products is find what your patient is afraid of, and then really gently go show the data and give the support and know, and ultimately, Donna, we're going to all have to look at each other and say, you know what? I made the best decision that I could on November 18th, 2024, right? I made the best decision that I could with all the information that existed in the world. That doesn't mean we have a crystal ball that says what's, like, you and I are both going to die. We are, right? And it's, the question becomes, how are we going to live, and what does life look like?
Yeah, how do you want to live your life? And I guess I just want to say that, right? Because I think when I was talking before about I was thinking a little bit more about systemic. So I apologize about that, because I think the systemic does have that, you know, risk, a little bit of risk benefit, right? Profile that's a little bit more than vaginal estrogen. And what you're saying is that vaginal estrogen, there's no study that shows that it causes any of those things that's on that box warning. And in fact, when you and I went to the FDA this summer, we put together, and I ended up putting together the data and looking at the data between DHEA and local vaginal estrogen. DHEA is FDA approved and local vaginal estrogen is not. I mean, it is FDA approved, but it has the box warning. But when I saw the data, the estradiol levels were in the same range, and it was in postmenopausal range. Like, it did not get up below that postmenopausal range. But what it does do, and maybe we can go through this a little bit, is in the beginning, it does a little bit more than after like 20 days or 40. Can you explain that a little bit to people, why that happens, why it goes up in the beginning?
Yeah, so in the first few days that you're taking a vaginal hormone product, there may be the slightest increase in your whole body estrogen levels. They really do not go up above menopausal range. They go up to, so just, I think numbers are really interesting here. So if you draw my blood right now, depending on where I am in my cycle, my estrogen level is going to be probably between 50 and 150. Okay. And that's picograms per milliliter, right? So my estrogen is going to be 50 to about 150, depending on where I am in my cycle. Mid-cycle, you're kind of at the highest. When I was pregnant, my estrogen was probably 3,000. Okay. So 3,000 for like 9 months, twice. I had 2 babies. My husband, who's out there taking care of those babies, right? His estrogen level is probably 25. Okay. So men, their estrogen levels are about 25. Menopausal women. So Donna just said she went through surgical menopause, which means she had her ovaries removed. So if we measure Donna's estrogen levels, it would say less than 5. So the number doesn't show you 0, but it's 0, right? It's essentially 0. So less than 5 is what our lab typically shows. When you give vaginal estrogen to someone, the data shows in the first couple hours, maybe, you know, the first few days, your estrogen level may go to 20, okay, like around 20. Now that's lower than a man's estrogen levels, and it's still technically in that menopausal range. Remember, my low is 50. At my lowest every day, my low is probably about 50. And so and as the tissue, right, the tissue is pretty thin, so it absorbs a little bit more. As the tissue gets a little stronger, a little robust, the data shows, one data set after 8 hours, right, after 8 hours, your estrogen levels stay down into that less than 5 range, right? And so that's why it's local. It doesn't help your hot flashes. It doesn't prevent your bone loss and prevent osteoporosis. It is local, but it does that local response is enough to acidify the vagina, bring the pH down, be healthy for your vaginal microbiome so the healthy bacteria grow, which means it fights urinary tract infections. And that relaxes the bladder inflammation enough so that you don't have frequency and urgency and leakage. It's just magical the way that it works that way. And so the numbers matter because, again, even if your estrogen goes to 20 for 2 weeks, say, which is not what the data shows, but even if it goes to 20 for 2 weeks, there's no data on earth to show that having an estrogen of 20 for 2 weeks is dangerous in any way for any patient on earth. And so that's where it's so important to understand numbers and sort of how something works. Now, there are people who want to take systemic hormone therapy, and I'm excited you're having a webinar with my idol, Dr. Mary Jane Minkin, who is my actual idol of who I want to be when I grow up, and was going to talk about the safety of whole body hormone therapy. But this is different than local vaginal hormone therapy.
And that what I saw in that is that they went down under to 8 and 5, like it went down really low. So it was just increasing it just a tiny bit, right? And just to give you enough to prevent those symptoms. So I think that's really important. We're going to take questions now because I think that will be really helpful to our audience. So we're going to take a question from Jackie. I've been asking my doctors about changes of my labia, and I've not gotten anyone who says it's GSM related. So frustrating. We hear you. Any thoughts on that? I've been asking my doctors.
What was the first thing she said?
Asking my doctors about changes of my labia, and I guess we don't labia, and we haven't gotten
labia. Yeah. So what I would we don't know. So labia minora that change, we actually don't know. I have a group of medical students working with this. I have a research team that is doing some research on the labia minora, and the science has not studied it, right? The most of the research that exists in the literature is on labiaplasties, when people want to cut off their labia. But there's very little data on the resorption or the disappearance of the labia minora and whether it's driven by estrogen, progesterone, testosterone. We actually have some ideas, but we don't really know. And so I wouldn't say that you should lead with your doctor with the labial changes, because they're going to be like, what are you talking about? I don't know anything about this. But if you're having urinary frequency, urgency, or recurrent urinary tract infections, even one urinary tract infections, you can be 45 or 38 or whatever it is. The American Urologic Association guidelines in urinary tract infection says that you should be offered vaginal hormones. And one of the things that we've done is I just turned 40, and my dream, which was for my birthday, was to start a YouTube channel devoted to asking or to answering all the questions that exist on vaginal hormones. So my team and I have done video after video, short video after video of talking about all these questions about vaginal hormones. So it's my name, Dr. Rachel Rubin. So what you see right there in the on the name, there it is. The name right there is our YouTube channel. And there's a whole lecture to doctors of like how to prescribe vaginal hormones. On our website, rachelrubinmd.com, under educational resources, we have a guide of how to prescribe vaginal hormones that your doctor can download to know how to write the prescription, why. It links to our YouTube channel. We're really just trying to give out resources to people so that because you have to understand, your doctor never learned this in medical school. That doesn't mean they can't learn. That means that you have to give them a break and say, hey, I know you didn't learn this, but this is now what the guidelines show. This is now what is helping people, and you can't hurt me. Like, there is no harm that's going to happen for this, and I feel pretty safe. So like, here, hand over the prescription. Like, again, and my job is to teach the doctors to get them to understand that it's safe and effective, and so they can learn new things. They can. That's why we are working on guidelines that we are yelling and screaming at for the FDA level, because it matters. It matters. It just because your doctor didn't learn it doesn't mean you shouldn't have access to it.
Mm-hmm. Right, exactly. I guess we did not get to our campaign. So I just want to, maybe we can briefly talk about it and then get to the rest of the questions. So Dr. Rubin, myself, Let's Talk Menopause, we formed a working group and we have a campaign. Otto will put the link in to the campaign to urge the FDA to remove the box warning off of local vaginal estrogen and to treat it differently. So right now, we said it treats them as the same, but sort of all estrogen is estrogen. And we want them to treat it local and systemic. And we don't know what's going to happen with the new administration, so stay tuned, but we're going to still continue to put pressure on it. And maybe that this is an opportunity to really get in there to be able to make that happen. Go ahead, Dr. Rubin. You want to say something?
I need, this is important. So there are well more than 100 people on this Zoom right now, and more people that are going to watch this. I need you to click on this link. If you're not watching live, I need you to go to Let's Talk Menopause / unboxing, because here we need to pressure the FDA. We need signatures. I need you to not only say that you're going to sign it, but I need you to promise that you're going to get one friend, one family member, anyone, a college kid. They need to sign this petition. Why? Because there are people dying and not having access to these life-saving therapies because of this labeling that exists that says vaginal hormones are dangerous. Vaginal hormones are not dangerous. And we can show you, and it links to all the data that exists so we can prove to you that that is not true. But this box is hurting people. And so we need your voices. We complain all the time that we have no power, that no one cares about women's health. Here is power in your hands, something that you can use your voice for and say, this isn't right. This is actually wrong. And we have to change that. At the end of the day, the FDA works for us, but they're not even listening about this point, and they have nothing to back it up with. It's bureaucracy. They can't, there's nothing that they have said that says, oh, that people aren't right about this. Every society, every OBGYN society, cancer society, menopause society, sexual health society agrees that this box should be changed. And yet we're stuck between bureaucracy. And so I need you to pledge that you are going to sign it and click on this link.
Absolutely. And there's other barriers that I don't think we have time to get into, but insurance and things like that. But these are all things that we're working on continuing the fight to get that done. So but I know people are concerned about their own questions and bodies. So is there an optimum dose of vaginal estrogen? Currently taking 10 micrograms a week. Thank you for this discussion. So useful. Thank you, Eleanor.
So I would stick to the labeling that is recommended on the box. It's okay to do regular labeling. So there's a little bit of ranges that we can do with that, but the 10 microgram vaginal insert, we typically recommend twice a week. You could even do 3 times a week for that. And again, one helpful trick that we use in our office that you can buy on Amazon is pH paper. Is you can take a little Q-tip, put it in the vagina, and then rub it on pH paper. And we want the vaginal pH to be 4.5 or less, right? And so if you get pH paper that is in that range of 4.5 to 7.5, the pH will tell us if you're doing well. So if you're using an insert, we typically recommend 2 or 3 times a week for the vaginal insert. If you're using the cream, similar, we use about 0.5 gram to 1 gram twice a week. You could do 2 or 3 times a week. And if you wanted to, you could take a little tiny bit and put it around the urethra and the vulva as well to kind of help with any irritation at the opening. But that is usually not enough if you just did that. You usually want to get at least 0.5 gram to 1 gram 2 to 3 times per week, sort of in the vagina if you're using a cream. And we typically recommend that you rub it in. So I tell my patients, put 1 gram on your finger and then rub it in like you would put sunscreen on your face, right? Really rub it in, because then it's not goopy, messy, leaks out on your underwear. These can't hurt your partner, right? If you have a partner and it gets on their fingers or on their hands or on their genitals or something like that, it's not going to hurt your partner. It's not going to cause them any systemic or whole body effects. If you don't want to be intimate when you're using it, do it after, right? Or do it on a day where you're not being intimate is totally reasonable. So we always get that question of, will it hurt the penis? It will not hurt the penis. I will tell you, it does not hurt a penis. Remember, men's estrogen is 25. If you add vaginal estrogen to their penis, it will not go up higher than 25. So you will not hurt the penis.
Got it. Okay, great. Allison asks, I'm curious if you all are finding a link between the gut microbiome health and GSM.
So it hasn't been studied fully, but there's no question that there is a link, especially if you're using a lot of antibiotics to treat urinary tract infections, then you're definitely going to mess up the gut microbiome. I am fascinated by hormones and gut microbiome sort of from a systemic hormone level, because there are hormone receptors in your whole body, in your eyes, in your gut, in your bladder, in your hair, like brain has full of estrogen receptors. So this would be a great question for you to come to the next menopause talk with Dr. Mary Jane Minkin, because I think that is a really important conversation. I do see when you treat GSM, we do see improvements in constipation. I had someone on my Instagram just this morning say, wow, it fixed my anal fissures. I didn't expect it to fix my anal fissures. And so there are a lot, because you're helping the whole pelvic floor. And so if your pelvic floor is supported with hormones, then you can let out the stool, let out the urine, have sex, and not leak so much. It's really supportive of all of those things. It keeps all the tissue down there very healthy.
Mm-hmm. And it's actually interesting because one of the things is, even though statistics show or studies show that it affects, 50 to 80% of women post-menopause, right? Clinically, don't you see it in almost all women?
Yeah, so we're trying to push this because these problems are actually not unique to menopause. There are many things we do to alter hormone status during the life cycle that can cause these genital and urinary symptoms. Even babies, right? Babies and baby girls, young girls can get labial adhesions and vulvovaginitis and recurrent urinary tract infections. And it's probably from a lack of hormones. And so we will even give young little girls vaginal estrogen to help with labial adhesions. It's a long-standing treatment. When you are on birth control pills, sometimes the way a birth control pill works, it actually can cause GSM-like symptoms of the bladder and the genitals. Not for everybody, but so we see a lot of people on birth control pills with pain with sex, dryness, recurrent urinary tract infections. And there is a role for using these vaginal hormones on these patients. It will not hurt them, but it will support and heal the tissue. Breastfeeding, we just coined a term called GSL, Genitourinary Syndrome of Lactation, which we've published on, and we're continuing to publish on our research team, which shows that while you are breastfeeding or pumping or anything like that, you have menopause hormone levels in your bloodstream. And so you will get all the same symptoms, the dryness, the leakage, the frequency, the urgency, and data shows using vaginal hormones is totally safe for you and the baby. It is not a systemic response. It doesn't go into your milk supply, and is totally safe to use, but is under discussed, and the OBGYNs aren't bringing it up with their patients. And there are patients with transgender changes that affect their hormones. So there are many times throughout the life cycle. Perimenopause is a perfect we hear it all the time. Well, I'm 45, my doctor won't give me vaginal estrogen. I'm 42, my doctor won't give me vaginal estrogen. It's wrong. They are wrong. And the American Urologic Association guidelines actually support you, because in those guidelines, it says perimenopause that you should be giving vaginal hormones. So just because you're getting your period does not mean you shouldn't have access to these life-saving therapies.
Oh my gosh, I learned something new from you every day. Okay, we're going to get to the questions really quick. We have 10 minutes. I've tried cream estradiol, a patch, and 3 different estrogen pills. None have helped. What's next? What's the data and on the efficacy of other forms? Also, Donna, can you ask what if the vaginal estrogen doesn't help enough with sexual pain?
Yeah, so here's where it is so important that you work with someone who knows what they're doing, and you see a specialist. And hopefully in the chat box, we can put both iswish.org and menopause.org so that you can find a provider. Now, just because they're on that list doesn't mean they are the smartest people in the world and know everything. But sometimes you have to see an expert and a specialist. People will travel to the Cleveland Clinic for a rare cancer diagnosis. Unfortunately, when it comes to complex pelvic pain or complex menopause issues or hormone therapy, sometimes traveling to see a specialist and investing in that is worthwhile. And many people out there who are, it's almost like, sort of you get the best high priced lawyer when you need to get out of jail, really like sometimes it is time with people. If you are not getting your needs met in a 10-minute visit, most people can get their needs met in shorter visits with local people. But if you are finding that you still have challenges, then you need someone who's going to work with you. Now, that doesn't mean they have a magic wand, but in order to get them to really understand, to diagnose, to look at your tissue and to see what happened, why aren't these therapies working? What I find is often people don't use them in the proper way. They don't get the right dose. They don't use it for long enough. and it's an education problem. Oftentimes people come to see us in DC or LA. We have offices in both locations, and it's really a knowledge problem. They may have gotten the right prescriptions, but they're not using them in the right ways, in the right for long enough, in the right capacity. And so this is where you may have to seek care outside of your town that you live in.
Okay, great. Okay, Charlotte asks, for somebody who's been in perimenopause since my late 20s, this explains a lot of things. Can you point me or anyone in the right direction for personal research?
Yeah, so I love resources, and I love giving people, like, you can't take hormones because Dr. Rubin says you should. You have to do your research. And I'm so grateful to my colleagues in this space, especially the Let's Talk Menopause, because they are giving so much free education. My friends and I are on social media giving tons of free education on our YouTube channels, on our Instagram accounts, on TikTok. And so are all accounts equal in their knowledge? Are all accounts 100% perfect? No, but you got to start learning. There's a lot of books, there are podcasts, there are documentaries recently. So there's a lot of really cool education that is out there. Some of our favorite people who are writing books in this space. And so follow any of us on Instagram or see kind of what these are. And we're constantly posting resources, and you'll quickly learn that there are the people who, who are trying to educate in this space.
And I would also say to that last question is, if you're in perimenopause in your late 20s, then you're going to be experiencing early premature, maybe, I don't know for sure, right? Premature ovarian insufficiency. And so, I mean, it used to be, and I have friends and, that unfortunately were diagnosed with early menopause or POI, in their early 30s, and were denied systemic hormone therapy. And I think, when we get to that next one, and I hope that you do watch the next one with Dr. Minkin, is that now the gold standard is to put everyone on systemic hormone therapy until the age of menopause, for bone health and for other various reasons. So we don't need to get into that fully, but I think that's something really important to look at. Okay. Rachel, Dr. Rubin, do you want to add anything to that, what I just said about early or POI?
No, I think it, again, these are the patients you absolutely must see a menopause specialist, because you are at risk for severe heart disease and significant bone issues, and you really need help. And hormones are good in those situations. And so you got to see someone who really understands. And I think, why is it that the time you get to spend an hour with a doctor is when you have a cancer diagnosis? Why is that the only doctor who will spend an hour with you? You have to, like your body, your decisions of how you want to live potentially 50 years of your life deserves nuanced and good conversations about prevention, about strength, about how you want to live these 50 years.
Yeah. One more question, a couple more questions. Upcoming hip replacement surgery. Currently on, so I think, I don't know if it's local or systemic. Surgeon says I need to go off a few days pre-surgery. Can you explain why?
Yeah, so this is, again, because your hip surgeon doesn't understand this to any degree, this is actually why we have a problem. And so it's true, if you are on oral estrogen, right? If you are on oral estrogen, like a birth control pill or Premature or oral estrogen, there is a small risk of increase in blood clots. And when you get a hip replacement, everyone doesn't want you to get a blood clot. Nobody wants you to get a blood clot. But if you're on vaginal hormones or even a patch or something like that, there's no increased risk of blood clot. And so your hip surgeon doesn't know this, and so I'm not telling you to defy what your doctor is saying, but you need to understand that they don't understand the nuances here. And vaginal hormones are really, really important to prevent UTIs, which can infect your hip replacement. So this actually tells me that my team and we need to be publishing more in the orthopedic literature about why this is important, actually. And I believe that women should be started on vaginal hormones 3 months before any joint replacement to maximally get them to not have infections, and we would save lives. My own family, I had a family member during COVID who had a knee replacement. And about 6 weeks after her knee replacement, she calls me up because I'm the urologist of the family. And she says, I think I have a UTI. I've got frequency and urgency. And I said, hey, have you been taking your vaginal estrogen? And she said, no, I just had a knee replacement. Leave me alone. I haven't been able to get up and about. I said, that's why you have a UTI, is because you're not using your vaginal hormones. So again, this is life saving. Like, do you think my family member wanted to have a UTI 6 weeks after a knee replacement where she wasn't getting around very much? I mean, this is why it matters. And the educate, because she thinks, oh, it's just for a little vaginal dryness. I'm not worried about that while I have my knee replacement. And yet she was very annoyed when she got the symptoms.
Okay, great. If we're on the estradiol patch and vaginal estrogen, which again, people can be on both, is there a need to test our estrogen levels? And if so, how often?
Yeah, you don't. So it is a really good point, which we didn't bring up. So thank you, person, for asking the question, because it's so important that if you are on a patch or a pill of estrogen and you have any signs and symptoms of urinary frequency, urgency, urinary tract infections, dryness, or pain with sex, you should absolutely be given vaginal hormones in addition to whatever it is you're on for your whole body, because it is often not enough. The systemic therapy is often not enough to treat GSM, and it doesn't add any danger to your entire package of hormones. And so it is often that I will prescribe both systemic whole body therapy and vaginal hormone therapy, because the systemic's treating the hot flashes, night sweats, and the osteoporosis prevention, and the vaginal hormones are treating the genital and urinary syndrome of menopause. And so typically, again, when you're using GSM therapies, there is no role for checking labs in this patient population, no role whatsoever. Your great grandma in the nursing home can take vaginal estrogen and you don't need to check her estrogen levels whatsoever. I will leave it to Dr. Minkin to talk about checking labs for systemic therapy, because there isn't much role for that either based on the guidelines, but there are some people who will spot check and make sure you're absorbing and things like it's a little bit more of a nuanced question. But for vaginal hormone therapy, there is no role for checking labs at all.
Okay, great. Oh, now we have more questions in here. Oh my goodness. Okay. Someone said not to use vaginal estrogen as a lubricant for intercourse. And so I just want to, I guess we should just clarify, there's lubricants and then there's the treatment, right? So lubricants, this is not a lubricant.
It's not a lubricant. It's there to, so almost think of it as the difference between sunscreen and using a moisturizer. So sunscreen is there to prevent the sunburn, right? But the moisturizer makes you feel good. So the vaginal estrogen is there twice a week just to heal the tissue and to prevent problems. But add all the lubricants that you want for a fun sex life. In fact, lubricant is good, but lubricant plus vaginal hormones twice a week will actually make you need less lubricant, and it will make it like way more fun and more comfortable.
Okay, great. So we got some last minute questions in there, and you know what we're going to do with those questions? We're going to take those questions for our newsletter in 2 months, where we'll put some of those questions in there. So stay tuned to that. So we really want to thank Dr. Rachel Rubin for joining us today. We could go on and on and on. You're fantastic, really, just a pleasure to have on here.
A quick plug for our newsletter, because we do have a newsletter at rachelrubinmd.com. So we do lots. If there's an article, I'll post it. I don't spam. So please feel free and follow us on social media. It's Dr. Rachel Rubin on the social media part. So and we need you loud. We need you loud to get this FDA change to happen.
Great. Thank you so much, Dr. Rubin. You can leave now. We're going to do a couple housekeeping items, but you're free to go because we know you have patience. So thank you. And thank you all of us for joining us. Ada is going to launch the survey, or someone's going to launch the survey through Slido. And we really hope that you answer those questions, because it just helps us with our programming, how we can improve. This talk is part of our monthly Menopause Talk series. The next Menopause Talk is on December 13th at 1 p.m. with the amazing Dr. Mary Jane Minkin. She is spectacular. She's funny, and she just tells it like it is. Please spread the word, like Dr. Rubin said, for people to sign up for our newsletter as well. The FDA campaign. Follow us on social media as well. And we are a nonprofit. So everything that we do here is, we are a nonprofit. So if you want to donate, that would be fantastic. So we can continue to provide those funds. You can go to our website for that. And are there any other slides? I don't think so. There's the FDA campaign slide. Maybe you can put that up there, Ada, if you see it. There's a QR code if people need that. So that's our unboxing menopause campaign. Right there, you can directly to the FDA, you can send a letter directly. Okay. So thank you very much, everyone. Thank you and have a great week. Bye-bye.